let's discuss difference between conventional oral anticoagulant, that is warfarin, and novel oral anticoagulant or directly acting oral anticoagulant. Starting with the mechanism of action of warfarin. Liver synthesize clotting factors such as 2, 7, 9 and 10. These are inactive proteins. These factors are rich in glutamic acid residues. These factors are carboxylated in liver, where vitamin K acts as a cofactor. Inactive vitamin K is activated by the enzyme vitamin K epoxide reductase 1 or VKORC1. Activated vitamin K acts as a cofactor for the enzyme gamma glutamyl carboxylase, which activates this clotting factor. Warfarin competitively inhibits vitamin K epoxide reductase 1, which prevents activation of vitamin K. This ultimately results in inhibition of activation of factor 2, 7, 9 and 10. Coming to the novel oral anticoagulant such as dabigatran and zimaligatran, they reversibly block the catalytic site of thrombin. Ipixaben, betrixaben, edoxaben and rivaroxaben, they inhibit factor 10A directly. Therefore, they are known as direct oral anticoagulant. Zimaligatran was the first oral direct thrombin inhibitor which was hepatotoxic. Therefore, it was withdrawn from the market. Dabigatran is recently approved. Warfarin has delayed onset of action. They act by inhibiting the activation of clotting factors, but those clotting factors which are already activated or which are present in the circulation, they remain unaffected. Depending on the half-life of the activated clotting factors, full anticoagulant effect following warfarin takes around 4 to 5 days. Thus, for rapid anticoagulant effect, heparin bridging is required, that is, combining warfarin with rapidly acting anticoagulants like heparin, low molecular weight heparin and fondaparinux for initial 4 to 5 days. In case of novel oral anticoagulant which inhibit factor 2A and 10A directly, they have immediate or fast onset of action. Thus, heparin bridging is not required in case of novel oral anticoagulants. Warfarin requires frequent monitoring of prothrombin time. INR monitoring is required initially. Once stable dose of warfarin has been identified, INR monitoring can be done once every 3 to 4 weeks. No APTT monitoring is required in case of novel oral anticoagulant when given in fixed dose gives predictable response. Thus, routine monitoring is not necessary. Bleeding is the more common side effect seen with warfarin and less with novel oral anticoagulants. Skin necrosis, lutein discoloration of plantar surface of toes are other side effects seen with warfarin. Incidence of GI bleeding is more commonly seen with directly acting oral anticoagulant than warfarin. Vitamin K is the antidote for warfarin. Idarucizumab is a specific antidote for dabigatran, while andexanet alpha is the newer antidote for other directly acting oral anticoagulants. Since warfarin is metabolized by CYP2C9 in liver and inhibit vitamin K epoxide reductase enzyme, enzyme inducers or enzyme inhibitors affect warfarin metabolism, which leads to reduced efficacy or increased toxicity respectively. Thus, drugs which are enzyme inducers and inhibitors are contraindicated with warfarin. Novel oral anticoagulants are PGP substrate. Therefore, they should not be combined with PGP substrates like vanidine and verapamil. Warfarin is contraindicated in pregnancy in patients with congenital coagulation factor deficiency thrombocytopenia, and patients with hepatic and renal insufficiency. Novel oral anticoagulants are also contraindicated in patients with severe renal impairment, except ergothropic, which is preferred in renal failure due to its liver excretion. Thank you.